a 75-year-old Caucasian male who had a previous history of cerebral stroke, laryngectomy, and radiotherapy for an adenocarcinoma, which was followed up annually. In 2013, a CT scan showed a gastric adenocarcinoma, which was treated with a gastric resection with Roux-en-Y anastomosis and chemotherapy. The last follow-up was in March of this year. An EGD showed a normal esophagus, regular gastrojejunal anastomosis, 20 millimeter granular type laterally spreading tumor on the greater gastric curvature. Biopsies showed a high-grade dysplasia. An EUS evaluation was not possible for post-laryngectomy stenosis. A smaller tube may have been required. A CT scan showed it was negative for metastasis or pathological lymph nodes. The hematological exams were positive for neoplastic markers, and there was no anemia. There was no recent weight loss and no melena. So today's procedure will be an esophageal EUS for staging, performed by Dr. Van der Merwe and Dr. Depre.
We have first inspected the lesion using the gastroscope. We performed the gastroscopy, and we could again document the laterally spreading tumor in the stomach as was described to you. We had some difficulty passing even the slim scope because of the stenosis at the level of the trachea, but we are now in the stomach, and you can see that we are delineating the gastric wall at the level of where we could see the tumor, or where we could see the lesion. So this is the balloon that you can see there inflated. One can see there water that I've introduced into the stomach, and one can see here the differential layers of the stomach. We could also see that there was quite severe atrophy using the gastroscope, but one can now clearly see the different layers visible. The muscularis mucosa, the submucosa, and the muscularis propria can very nicely be seen. So I think that at this level, certainly we don't have any evidence of an infiltrating lesion. Some thickening, and I'll try to show you that, of the mucosa, but certainly no evidence of any infiltrating lesion of the gastric wall. So this is...
That's very nice resolution, even with 9 megahertz. I mean, you could go up to 10 as well, couldn't you, with that probe, I believe?
Yeah, we can certainly do that, go up to 10 and see if we can even improve the resolution further. So I cannot decipher more layers than what I have shown you, but maybe with the 10 megahertz we can even see the lesion better. So I'll try to show you some of the thickening that we observed. This is, maybe one can look at, you can look at the endoscopic view as well, and you can see the superficial lesion over there. I'm trying my best not to damage the mucosa and make it difficult for Pierre when he performs a resection, but you can see there the laterally spreading tumor in the distal stomach. So in this area, if we can focus there, one can see that there is some thickening. Certainly there's no invasion of the submucosa, but there's certainly some thickening of the mucosa seen here, which is compatible with what we are observing. At this level we can't see the muscularis mucosa, but certainly the muscularis propria is completely intact, and we can see that the submucosa also shows no hypoechoic changes compatible with a Lenitis picture. Pierre, what do you think of this image?
Yeah, I think you showed a perfect image of a mucosal lesion, a superficial lesion. One might ask if there is, if EUS is necessary before treatment of these lesions. So, do you think there is a systematic indication in superficial tumors of the stomach?
No, you're absolutely right. I think often one will decide to resect the lesion based on the endoscopic image and not necessarily on the EUS image. If there is doubt, obviously EUS is helpful.
Yeah.
But in this case, I think probably with lifting you would have had the same benefit as we are now trying to demonstrate with EUS. But this is certainly a...
But the also point is that EUS will pick up nodes, which would of course contradict local resection,
Yes.
would it not?
No, absolutely.
Isn't that the value of EUS?
So you see the lesion is it's an elevated lesion. So I would call that Paris 2A lesion. And we clearly see the limits. You see that's the suction during the EUROEUS examination. So I'm going to mark all around the lesion, leaving a margin of about 3 millimeter. And then when I start the dissection, I will do it outside the margin, so that would leave us with a margin of 5 millimeter, around 5 millimeter. Please, no knife out, never, never, except if I ask you, because that's very dangerous. We know that it's a very atrophic gastritis, and you saw that the submucosa was quite thick with EUROEUS, meaning that there is a lot of fat in the submucosa, which may make it complicated due to a bad vision during dissection. I'm using the dual knife, and I'm marking it now all around using force coac effect 2 on a Vio 300. With CO2 insufflation. And when I finish the marking, yes, in this case, there was no need for chromoendoscopy. In some patients with a lot of intestinal metaplasia in the stomach, you may need some chromoendoscopy, and then I usually use a combination of indigo carmine and acetic acid. So you see the lesion that's demarcated now. I will put another dot here. Okay, so next step then is injection. We will start the injection to elevate the lesion. Sometimes in the stomach, when there is no good elevation, it doesn't mean that the lesion is not resectable. It may just be due to previous ulceration and fibrosis in the submucosa. So we usually don't do EUROEUS for flat lesions in the stomach, because in many cases the endosonographer overstates the lesion as a submucosal infiltrating lesion, and then ESD may be reconsidered on basis of submucosa that looks infiltrated, but it may just be due to fibrosis. So we use a Cook needle here, a 23 gauge Cook needle, yes, needle out. And we use a solution that's a combination of glycerol and glycerin. Yeah, can you start the injection? Yeah, good lifting. Can you count? Yeah. Okay, so elevation is going perfectly. I usually, stop. I'm very cautious in the, no, needle always out, please. Okay, yes. And then I use the limit of elevation, yes, okay, again, to elevate further. And I usually do that for about 1 or 2 centimeters. Stop, yes. And then we go to the next step, yes. Elevation again. Okay. And this is nice to me, yes. Needle in. And we go for the dual knife. Yes. And then now we start with the dual knife to do the circumference incision, going from here to here. Usually it's easier from the left to the right because you see what you do, but it depends on the scope. With the Pentax scope, you see that the instruments coming out at I think the 5 to 6 position, and when you use Olympus scopes, it's usually 7 and 8. So it make a difference, and maybe in this case, it may be easier to start from the right side. Yes, needle out. And the incision will be done in the endocut mode. Endocut Q. Sorry, I'm a little bit bothered by the pedal here. Yeah, sorry, I need my free space for pedal. Yeah, okay. We go back again. So the knife is out. And I leave the dual knife outside You see the white part outside, and I just go over the markings slowly, trying to get to see the next marker, and doing this in one step. One step more, I think. Okay. And then I usually put a knife in, and you see the fatty tissue that's already visible here. So usually when I perforate it, it was in patients with atrophic gastritis, because sometimes it may be very difficult to distinguish the submucosa from the... So the knife is in.
Pierre?
And then I use swift coagulation, effect 40 watts, for the dissection. Yeah, so it's what I thought it's a complicated case because there is a lot of atrophy. Yes, stop. The patient is bleeding quite easily, so I had quite an important bleeding, but I could stop it. Needle out, always out, please. Yeah. Yeah. But so I'm doing my circumferential incision, and then I think I will move to the IT knife, which may be easier to use because I'm quite perpendicular to the in my approach here to the lesion. So you see I inject quite a lot to be sure of my safety. Yes, injection. Yeah. Okay, and we take needle in, and we use the dual knife again. You see I had quite severe bleeding here. I had to use the hot forceps in soft coagulation, effect 480 watts to control the bleeding. Now I continue my cutting. Yes, knife out. We should shift to swift again. Yes, and we endocut. Everything is perfect. I like to use endocuts for the first part of the cut to be sure to have a clean pathological specimen. And then later on, then I use coagulation to do the coagulation. But in this step, I like to use a cutting without too much coagulation. This was the site of the bleeding. You see, I'm not very stable in my approach. It's quite jumpy in front of me. Need a knife in, please. So I'm going to try to focus on the part where we had bleeding. But you see, there are many movements, not very stable. But otherwise, I did some work here, as you see. There are still some attachments due to vessel. So I'm going to cut this also to show you that we did some work already on this side. I have to take into account the movements of the patient. And you see that's the muscle here. The yellow, yeah, you see the muscle. Yeah, you see the muscle fibers there. So in a patient with atrophic gastritis, you have to be very careful. Knife out. Yes. Okay.
So is there anything that you can do, Pierre, to improve your plane? Can you inject some extra?
Yeah, I will inject some more later on to get really under the plane here, under the lesion, and I will use the IT knife, which allows me also to go under the lesion. But this will be for a later step. You see here, once I will be able to put my cap under the dissection will be faster, of course, but this will be for a later stage. I want to finish now my incision around the lesion, and then you see we did some dissection already on this. but I have to continue here, of course.
Yeah, does this patient has a general anesthesia?
Yes, yes. But in fact, he had a laryngectomy, so he's intubated. So I think there was no really. I think it's safe in the way that the patient is not moving, and for the anesthetist, he can do something else. I think she's very good, but you could sit and read like my anesthetists do during those procedures that may last an hour or more. But for this procedure, I really like to use a magnification scope because we like to see knife in, please. We like to see the different layers. And you see in this case, the focus of the scope is perfect. But when I approach the submucosa, the focus is not, I think, perfect for this kind of job. But it's a very good scope in the way we have water jets. So this is very important when we want to control bleeding and wash the bleeding side. The knife out, please. You see, usually when you have this knife in, it's usually with a vessel. The white part is the artery and the reddish part is the vein. We are well in swift coag, huh? Yes. Once you have a nice blue plane, then it's of course easy to dissect. And you see the vessels here surrounded by fat. You see and that explains also why my vision is a little bit bothered by the fatty content. The Japanese, they have a special solution to clean the lens when they treat patients with atrophic gastritis. But I don't know the composition of this tissue, of this solution. Okay.
What is the Japanese secret to clean the lens?
They take the scope out and they clean it. Huh? They have usually a nice assistant who has a lot of different caps, solutions to take care of those problems. We have indeed very few gastric indications for ESD. Most of the ESDs we perform are ESDs in the rectum, of course, and in the esophagus for squamous and sometimes large lesions in Barrett's. But for gastric lesions, we have very few lesions that are treatable by. Yeah, I cannot show you better image. I will try to clean the lens later on, but we maybe continue the cutting there, and then I will need the cleaning. Yes, knife out, please. Yeah. You see, it's a bleeder. Swift coag is a nice knife in, please. You see, once there is bleeding, the best is then to retract the knife and go for coagulation of the vessels if you see them. But you have to be very careful because we are very close again from the muscle.
Can you use soft coag as in a cutting motion as well if you're close to the muscle?
Yeah, so then you see I put the knife in. Yeah, I'm losing my pedal again. Yeah. You see a big vessel here. So either you use a forceps, hot forceps, or you can try with coagulation. You see, I'm trying with coagulation, and if it fails, then you use a hot forceps and soft coag. That's what we're going to do, because otherwise we may take risks for delayed perforation. You see all those vessels that are keeping the central specimen attached to the outer margin. Yes, closer. Yes.
Pierre, you are still rather perpendicular to the surface.
Yeah, I'm too perpendicular. That's because of the location. Yeah, I tried.
Could it sometimes help to change the position of the patient, maybe?
Yeah, but he's quite fat. It may help indeed.
Yeah.
Yes, you're right. But I think I will use another knife to overcome this problem. Yes. Forceps open. But that's right. You're fully right. Yes. Okay. Close. Yeah. And soft coag, please. Of course, you should shift to soft coag again.
Yeah.
Okay, stop, open, close. Okay, open. Water infusion is important, of course, to keep a good control on the bleeding side. Yes, close. And in fact, the solution, I don't know what's the solution here, but the washing solution should be sodium chloride, because otherwise we may have problem for conductance. Yes, close. Okay, close. Open, sorry. And then I think we will clean the lens a little bit. I think this is okay. Yes, close. Open, sorry. Close. We're going to clean the lens here to finish the incision outside. So you have to be able to deal with bleeding, of course, and also with perforation. So we prepared some clips. We usually use normal clips. That's this stricture in the upper esophagus. You see it's very narrow, okay. With the cap it's a little bit bigger, it's about 11 millimeter. And sometimes when we have a large perforation, we like to use the Ovesco over OTSC clips to close perforation if it happens. In this case, when it's atrophic with a lot of bleeding and a lot of fat in the submucosa, may happen, of course. Okay. So we'll re-inject and then, yeah, you see, we have to really clean it from time to time. The first time I had this problem with fat spraying on the lens was in a life, and I didn't know really what's happening to me. And then Naoisa Yahagi, who is my teacher, told me that, you know, in Japan it happened very often, and they have a special way to get rid of that. Yes. Sorry, injection.
Sorry,
Thank you.
my mistake.
No, it's okay.
Sorry.
Once the incision will be made, I will try to find another position to be more tangential and try to be a little bit quicker than on the dissection. But you see, it's an operated stomach, so there isn't much place to bend the scope. You see, I cannot really do the retroflex position here. I can only work in the forward position, which is not good in the stomach. It's very nice in the stomach if you can work in the retroflex position. Yep, needle out, injection. Yeah, stop, it's okay. You don't need to over-inject because it will be more complicated for further injections. Yes? Of course, you can do this also with a flush knife or the hybrid knife. But when it's a difficult case, I usually prefer to use the slow technique like here, because it's usually quite safe. Yes. Thank you, thank you. And one more here. Even if it's a little bit slow, it usually works. Okay, perfect. And the dual knife again. Or we can maybe try with the IT knife. I think we are here in a very good position to use the IT knife. And we see, we are advancing very slowly here. We have a lot of fibrosis, as you see. Yeah, but you see there are many vessels, and you see this should be clearly blue. We're going to inject here again. And you see this is fat and fibrotic tissue. At some stage, we may take a snare to complete the resection, but I think it's a little bit too early to do this. And the problem if you snare it is that you can cause severe bleeding, and then you may have several slides of bleeding. So you should avoid to do it as much as you can, as we can. Yeah, injection. Yeah, but it's... okay, so we inject again. Okay, yes, and then we take the IT knife again. So we do injection step by step. You see this is getting better here. The more the lesion will hang from the muscle, the best it will be. In my unit, what we do in these cases is to use a clip and thread technique to pull the lesion through the mouth to have a better plane. But I thought I had to do EUROEUS today, so no ESD. Okay, open the knife. But it's okay, we can manage this case. So you see, I cannot be very perpendicular to the tangential like I would like to be. I will try to force the tangential approach here, doing this. Knife should always be open, huh? Yeah. You see, not easy to lift. Okay, let's try again here. Without cutting in the specimen, of course. Again, we put it further away. The trick with the IT knife is to go really under the lesion, so this is better. And then to bring it back to you. But you see, by doing this, if you do a large cut, you may cause bleeding. And then we have to find the site of the bleeding. We try to find it. What you can do then is to go back with the knife and use more coagulation on the way. Flush fluid, go back under the specimen. And if we can't control it, then we use again the and this is a patient with previous operation, yes, hot biopsy forceps, yes. Can you immediately close it so we can get it down? Close it, please. Close it, close it, close it, close it, please.
Soft coag here.
Okay. And soft coag again. Usually you keep your position. You use a cap to apply pressure, to compress the area. You try to find the vessel that you just cut. Yes. Open. And then you go for soft coag, yes, close it. Until you see the boiling point, you open it, you flush, and you see if there is more. So that seems to be under control, but that's maybe not the only Closer, closer, close, close. Maybe not the only site of bleeding. We have to check if there is not another one. And again, we try to go under the... Okay, we saw that there was another bleeding site. So we try to get some flushing. You see, the flush is very important, especially in these cases. Rectum and gastric can bleed a lot. Or you see the large vessel there. Open the... Not easy to find. I guess there. Close. Coagulation. Okay, open. I'm not sure it's the only... is the flushing working? Yeah? Okay, yes. So we have to find a spot, the bleeding spot. I try to avoid clipping until I'm at the end of the resection. I don't see the bleeding point very clearly now. Yes, there, it's there above. Okay. Open the... I'm slowly getting rid of all the bleedings. We had severe bleedings at several places, and we are still busy. You see, this is the muscle. The muscle is okay. We had a lot of perforating vessels here. We were able to treat the bleeding sites, and now we also prepared a snare to be sure to finish this on time, although we don't know how much time we still have in this case. But you see, we still have no perforation, which I'm very happy, because I think the perforation was what I feared the most in such a patient, where you have a very perpendicular approach.
But Pierre, you should do it like at home, and so you should not feel urged by the time schedule.
No, I understand. Yeah.
This is an extremely difficult case, I think, and if you take a snare or not, do it like at home.
Yeah, we see. I usually don't use snares, but we use hybrid procedures in the rectum, but usually not in the stomach. Usually in the stomach it's not necessary.
I think could be risky to get into the wrong layer when you take the snare now.
Yeah, that's also the problem. Yes, indeed. The plane is very, very difficult to find because there is a lot of fibrosis, and
Yeah.
as you see.
So I think you should go millimeter by millimeter. This is
Yeah, indeed. We are going to re-inject because I still don't see the blue. You see, sometimes easy cases look finished to be very lengthy cases, so it's difficult to place ESD cases in a normal program or in a program where you have EUROEUS or other techniques.
And it's becoming more and more difficult the closer you come to the center, isn't it?
Yes, it seems there is more fibrosis, but there was no ulcer during the endoscopic diagnosis, and it was incidental finding, I think, if I remember well, on the follow-up of his gastric adenocarcinoma. Yep. Okay, yes, injection. Oh, slowly. When it's so fast, it's not good. It means that we are not injecting properly. Yeah, injection. No, you see, it's not going. Stop, please. We go very slowly because if you start to inject the muscle, then you lose a very. Is the needle out? Yeah. Okay. Is the needle out? Sorry, I don't see the needle. I don't see the needle. Okay, there I see the needle. Okay, yeah. Yeah, okay. Yeah, okay.
Perfect.
Okay, that's fine. Okay, let's try here with the IT knife again. Also trying to have a tangential approach. Yeah, you can open it. Yeah, open it. Yeah, thank you.
It's a very nice plane, Pierre.
Okay, so this is better than what we did before. So maybe the more the lesion will hang away, the best plane we will get. But you have to avoid putting the knife, of course, where you see muscle fibers. Okay. Once more, same. I really tried to find another position, but without any success doing this. It's really at a point where you cannot. So maybe if you use a very special scope with the S-type or prototype, where you can bend it in different directions, would be interesting, but and you see once I start to burn the tissue, it damages my view. Okay. Muscle fibers are on the right side and the specimen on the left side.
You did not change the position of the patient, did you?
We can try. We'll try that for the last part. I don't think it will change a lot here in this case, but we can try. And no, we cannot do it. Yes, yes, yes. We cannot do it. Sorry, we forgot that he had pacemaker in his. Where is it?
In the right leg.
In his femoral. So we cannot move him. Well, we are going to succeed. I think we're slowly going this way. You see, we have a good plane here. We have to be very careful when we see a hole, of course. But I think it's not a hole in the muscle, but a hole in the fibers. Or in the mucosa, but not in the muscle. Oh, this is getting started looking better. No, it's me, it's me, it's me. Yeah, once the lesion starts to fall off, then we win. I think we win the battle, of course. Because now we know exactly where the plane You see, even with a cut without coagulation, it's not cutting very fast. It's very slow, and you see, it's not bluish. The mucosa is not bluish, but it's always white. So I think here we found our way down. To get rid of this lesion. Yes.
I don't know if you like this information or not, but in about 1 minute we will finish, and maybe you like this information. But already now, everybody sees that this is an extremely difficult ESD, and you are doing a fantastic job. Do not feel pressed, and I think you made a wonderful progress up until now, and certainly you are the hero of this meeting. Yeah.
Yes. Yeah. Eye scan is before the resection, but not during the resection. No, no. I would like a scope with a closer focus. You see, that would be interesting. But it's okay now. I think we have a. We see. No, needle first. We inject here. I think we have now a good. I don't think I'm too deep. I hope so. Do you have Ovesco clips here?
Yeah, we have.
Okay. If we need to close something. No, don't.
That's a bad sign, Pierre.
No, but.
Oh, no.
Okay, needle out. Yep, okay.
Dici tu di preparare l'ovesco? Voleva l'ovesco?
Could be difficult
Okay.
to pass the Ovesco through this narrow esophagus, isn't it, Pierre?
Oh yes, for sure. Yes, it will be impossible. You're right. And you see the fibers that are mixing with the muscle. Yeah. But now it looks much better for me.
Hello. So. Yeah.